Hi and welcome back to another video of Medic Notes. This video is on primary survey and resuscitation in trauma cases. The most common method of initial trauma assessment in the United States is based on Advanced Trauma Life Support, ATLS course from American College of Surgeons. The goal is to treat greatest threats to life immediately. Lack of definitive diagnosis and detailed history should not impede therapy. Trauma patient can present to the ED from multiple different scenarios. Blunt trauma, motor vehicle collisions, falls are most common. Penetrating trauma from guns or knives, environmental injuries, burn or cold, electric, smoke, or bite. Precipitating factors to trauma must also be considered, the 6S. Seizure, syncope, sugar hypoglycemia, suicide, sleep abnormality, and sauce for alcohol. For trauma cases, first we assess the patient by doing primary survey using ABCDE. A for airway. Look for signs of obstruction, like agitation, confusion, respiratory distress, failure to speak, cyanosis. B for breathing. Observe for altered mental status, chest movement, nasal flaring. Listen for signs of obstruction like stridor, asymmetry, air escape. Feel for tracheal shift, crepitus, flail segments, subcutaneous emphysema. Objective signs are rate, oximetry, ABG. C for circulation. Look for evidence of shock. Shock in trauma patient is hemorrhagic until proven otherwise. Early signs are tachycardia, tachypnea, narrow pulse pressure, reduced capillary refill, and cool extremities. Whereas late signs are hypotension, altered mental status, and reduced urine output. D for disability. Level of consciousness assessed by Glasgow Coma Scale, which is a good indicator of injury severity and neurosurgical prognosis. Change in GCS with time is more relevant than absolute number reported as three-part score based on eye movement, verbal response, motor response. E for exposure or environment. Undress patient completely and assess entire body for injury, log roll to examine back, and digital rectal exam. This table shows the GCS scoring based on eye opening, verbal response, and motor response. Full mark would be 15 out of 15. For management, resuscitation should be done at the time as primary survey, with focus on ABC. For airway, protect C-spine, head tilt or jaw thrust to open airway, nasopharyngeal airway if gag reflex present without concern for airway loss. And oropharyngeal airway if impending concern for airway loss or gag reflex absent. Definitive measures include endotracheal tube intubation, if unable to protect airway, inadequate oxygenation, profound shock or anticipatory in trauma, overdose, CHF, asthma, COPD, smoke inhalation injury, or anticipated transfer of critically ill patient. However, it does not provide 100% protection against aspiration. We can consider surgical airway if unable to intubate and unable to ventilate, which is by crocothyroidotomy. For breathing, consider nasal cannula, face mask, CPAP or BiPAP. For circulation, monitor vital signs, ECG, and oxygen saturation. If bleeding externally, apply direct pressure and elevate extremities if possible. Do not remove impaled objects as they tamponade hemorrhage. Impaled objects are only removed in the operating room, and use tourniquet as last resort. For resuscitation, give crystalloids and consider packed cell transfusion if severely hypotensive. If specific blood unavailable, use safe O blood. With significant hemorrhage, massive transfusion protocol may be necessary. Advanced cardiac life support algorithm is necessary for arrhythmias. Foley catheter and intube if indicated. Contraindications to Foley insertion include blood at urethral meatus, scrotal hematoma, or high-riding prostate on digital rectal exam. Whereas contraindications to intube insertion are significant mid-face trauma, and basilar skull fracture. After first resuscitation and primary survey, proceed to detailed secondary survey and definitive care. That's all for this video. Thank you.